Medical Association. Thank you all for being here and attending. And we are very pleased to see our incredibly special guest, who is Mark Noon. Mark, hello and welcome.
Hey, Dr. Davis, thanks for the opportunity to be here.
Who's Dr. Davis?
That's you formally, isn't it?
Oh, that's right. So I thought my wife was around somewhere. Mark, you and I have had the joy of knowing each other personally for a little bit of time here.
Yeah.
Will say that my experience started with you as a mutual friend who had introduced us because I'm looking for some leadership coaching. My business on a new role and new responsibilities, and so I felt I needed the help of a professional towards that end, and that's kind of we're introduced to each other. And then I've had some private sessions with you that have kind of helped me to elucidate a lot of what my vision is for the future. This and our place in it in the medical community. So that's been my personal experience. But why don't you tell us what you would say you do?
Well, that depends on who you ask sometimes. So, we ask our wives, that's a whole different story. You and I met several months ago, again, like you said, through a mutual friend, talking about leadership. But, my experience in leadership goes back now at least 25 years, my military days. I retired from the Air Force in 2012. From that point forward, I started working with a company called the Studer Group, which is for many in the audience who are listening today are probably very familiar with the Studer Group out of Pensacola, Florida, Quint Studer, but who also then that company also sort of morphed and was acquired by Huron Consulting Group, which is again a healthcare coaching organization. So I spent 8 years with them, working with hospitals all over the nation, into Canada, speaking on leadership, teaching on leadership, coaching on patient experience, which is some of the things we're going to talk about today, particularly working with doctors' offices, medical practices, medical centers, all different sizes of the healthcare world. In 2020, I branched away from there and went out on my own to do the same type of stuff, but in a sort of more broader sense. So I'm not strictly in healthcare anymore, although I was just in Washington State last week doing some leader development, some coaching with a very small little tiny rural hospital southwest of the Seattle Tacoma area. So lots of years of this. My clinical background is clinical laboratory. That's what I did 20 years in the Air Force. So I have a lot of hospital experience in that, as well as those 8 years of coaching and doing leader development in all different kinds of settings in the healthcare world. So that's sort of that background. That's how you and I ended up together, working together with you and your team. And what I love too, I just want to say this, Donnie, is I love the vision you have for healthcare and what you see as the opportunities to really improve upon what already exists there in healthcare. And that's where you and I have really connected and had a good time sort of launching that vision that you have.
Yeah, well, thank you for mentioning that. I will say I don't know what went wrong in your career to end up with somebody like me, but either way, here we are. Now, I do want to point out that I think if I had to delineate out what your ninja Jedi superpower is, it is to somehow make the ideas come out of whoever your client is. In this case, my personal experience, I don't know. I feel like you're part therapist, you're part psychologist, you're part motivator, and you're part coach. And I've been impressed every single time I walked away from a session going, oh my God, he was great. How did that happen? I didn't even know I had that in me. So thank you very much for bringing out something that I didn't know that I had in me. And then secondly, I'm sure this is not the first time you've heard that kind of refrain. So I think everybody here that's going to be witnessing this is kind of in for a treat about kind of your experience and some things you can bring to the table.
Yeah, it's like a therapy session sometimes, coaching is. But what it really comes down to is just like you as a provider, asking the right questions of your patient to get the information that you really need or that they really need to bring forth, right? You could walk in with the assumption of what's going on with them and just say, I'm going to treat you with this, this, or this. But when you ask really good questions, that's when you diagnose very well and you get to the heart of what's going on. And you sort of get to the root cause, if you will, of whatever's, going on with them. So it's the same thing in healthcare as it is in the coaching from a leadership perspective.
Mark, that kind of dovetails nicely, I think, with where we're trying to kind of lead here today, which is that, where's our locus of attention? Where should that be in our society, in our community, from a leadership perspective, and in our day-to-day practice? And ultimately, where the rubber meets the road, I think, is the patient experience. I mean, that's what we're really trying to optimize for. That's certainly where my vision has led. I've kind of said it slightly differently, that I think that we're in the customer service business, and I think we do very well to realize that. And we need to kind of hone in on what that customer service experience would be like. And if we can, in the Emerald Coast Medical Association, if we can empower our physician membership to be able to focus down on that patient experience, I think we would benefit quite a bit as a society.
Yeah, absolutely, we will. And we're going to delve into this, what I call the 3 C's of patient experience. And, we have gone from patient satisfaction to calling it patient experience. And I think there's some legitimacy to that, because satisfied is typically a one-time event. Experience can branch beyond just a moment. The same thing when we deal with leadership. We talk about employee engagement. It used to be employee satisfaction, and really we moved to this word engagement. And I don't know if there's a better word than patient experience, but I think about my experiences, if you will, in the healthcare world as a patient, and what drives that loyalty, if you will, what drives people to recommend you as a provider or your practice, to be able to receive healthcare. What is it that drives them to tell their friends, this is the person you need to see when this goes wrong? The patient experience, all of you who are in the medical world, all of us who have been in healthcare for these years, our number one goal is that people don't need us, right? I mean, it's to be healthy enough that they don't have to come back and see us, but we know that they're going to come back and see us. If they're going to come back, we want them to come back. We want them to feel welcome to come back. It's not that they dread going, oh, I got to go see Dr. Davis again because whatever. It's, wow, I'm not doing well here. I need some help. I want to go see Dr. Davis because this is the experience I have, right? So those 3 C's is where we're going to kind of delve in the next 20 minutes or so. Not going to give you every detail of everything, because we do 2 and 3 hour workshops on this very topic. So obviously in 20 minutes, we're only going to just sort of scratch the surface of it.
Well, I think that surface is going to be really interesting to us, and maybe whet our appetite for a little bit more. But I certainly I try and emphasize to medical students, and certainly all the members here and the board members can attest to this, that when we're seeing patients, the vast majority of the times they are incredibly vulnerable. They're in a scared position. This is not some place that they're familiar with. Part of some may say that the whole idea of going through medical school is so you can navigate the healthcare system. That's the real benefit of this. It's not anything else there. So they don't understand necessarily how to navigate this healthcare system, and they know that they're not feeling right. And so how can we start to make sure that we're addressing that, but also have a focus in on their experience, and not just on, there's several different layers towards fixing the problem, if you will.
Yeah, there is. And we're going to jump right into those things. So the C3 idea of communication, and sometimes I call it the C4 if we're going to talk specifically about communication as well, is really this idea of concern, coordination of communication, and confidence in the person or the product, or in this case, the medical practice. It's how do we address things with people? How good are we at communicating between our staff? How confident are they in our abilities as medical providers? And this really stems from a lot of surveys that have done. All of you who have been in practice any length of time have had surveys done over the years, either by governing agencies or just local surveys that you've done. And what we've found in these surveys is there's a correlating factor to the likelihood that people are going to recommend, or which is actually one of the questions, especially on a hospital surveys. But what's the likelihood to recommend? What's the likelihood that I'm going to say to my friends, hey, if you need this specialty, go see this particular provider? What's the chances that, what's the correlation in that of truly feeling as though you've gotten the best healthcare? Because the experience that people have is going to, for them, judge their healthcare. It's not about whether you diagnosed as much as is how you got to that diagnosis. And unfortunately, you don't go to medical school to learn how, to necessarily do it. You learn how to diagnose. You learn all the ins and outs of what's going on in the patient. That experience is something that what I've seen anyway over the years is it's not taught a lot, right? So how do we combine those things? How do we ensure the things that we say and the things that we do are going to give that patient the confidence that they're getting the best healthcare? Does that make sense?
Yeah, Mark, I have a saying that kind of goes along with this, which is, what is the best medication for a patient? The medication they're going to take. So it almost doesn't really matter. Most of the physicians that will be watching this will understand in the first several seconds, if not minutes, what they want to do with the patient. The rest of the time is getting the buy-in and getting them to make certain that they trust, and all the other things that I think you're going to cover here.
Right, exactly. So let's jump right into this, and we can, I can talk through some examples, and you can ask whatever questions you think are appropriate for that, and however long we take to get through it, we'll make it happen. And so this idea of concern is an interesting thing, is that we actually use the word concern in our conversation. I think that's the important part of this word concern. It's sometimes, how the brain operates is we've got to tie a word to an experience in order to sort of correlate the two or combine the two. If I did a survey, and these are surveys that medical practices, just like your practice, have done, it literally will say as one of the questions in many of the surveys, were all your concerns addressed? Well, in you as a provider or your staff, if they're talking to a patient and they use the word concern in the conversation, the likelihood that people are going to go to that survey and say, oh, they were concerned because they actually said the word concern. Well, so it's not a manipulation, it's not a trick, it's really addressing the concerns, and by using the word. Think about it like this. I've coached a lot of ER doctors over the years as well, and they're in a hurry. They're typically, they got so many patients and they're way behind, and they're trying to catch up, and so they walk in and they just start jumping right into the diagnosis or jumping right into questions. If they were to just stop and say, what concerns you most about your visit today, they would save so much time. Because what ends up invariably happening is we go into an exam room and we start to treat the patient, and it can be a very good experience. But then there's always that moment, you've probably seen this. I'm sure you've never done this, Donnie, but you've seen doctors do this. They go to the door, right? And they put their hand on the doorknob, and that's the point they say, is there anything else you need? Hoping that the patient says no, so they can go out the door, right? It's sort of that
the implied no there.
Yes,
hopefully you got
exactly, right. And then you get the ever famous question, oh, by the way, and then you find out what they're really there for. And so if we address this in the beginning, let me give you a great example. I was seeing an orthopedic surgeon several years ago. I had knee surgery in 2001, ACL repair. Did well with that for many, many years. Was in the military, of course, had to run all the time, had to continually, stay in shape. Got out of the military in 2012. About a year and a half later, I'm training and running a half marathon. It's the only one I've ever done, the farthest I've ever run. So early 2014, I go and run a half marathon. Did very well. But of course, after that much training, my knee starts to act up, right? Arthritis, whatever's going on with it. That January, my family and I decide we're going to take a ski trip in March. So I go to my primary care doctor. I have an appointment. I say, hey, I'm having some pain in my knee. She says, okay, she does a few tests. She says, okay, I think we're going to do an MRI and we'll send you to an orthopedic surgeon. Normal referral process. Get the MRI done. I go to the doctor in February. I go in, the orthopedic surgeon, no offense to some of you out there, but I had to wait about an hour and a half for my appointment before I got in, right? So I'm already
That's
way
it?
behind.
How'd you get in so quickly?
My first orthopedic appointment in 2000 was 4-hour wait, but this was an hour and a half, so it's pretty good. I was feeling good about it. But so I go into this appointment, and the doctor comes in, and he's friendly. He introduces himself. And then he immediately sits in the chair with his back to me, right? You've seen this happen. He starts looking at my MRI. He starts talking about surgery options. He starts talking about injections in my knee, all those things. What was my number one concern to be there? Was, can I go on this ski trip? Do I need a brace? Is my knee strong enough? So after 15 minutes of him talking about all these things, I should have just interrupted him. I didn't, but I let him go on his thing. He gets done doing all the things he's supposed to do, asking me all those questions, making the assumptions, this is what I'm here for. He said, is there anything else? I said, yes, I'm going to go on a ski trip in a couple of weeks. Am I able to do that? Now, what was a 15-minute appointment becomes a 25-minute appointment, right? Which puts him further behind with his other patients. What if he had just walked in and said, Mr. Noon, I see you're here for some knee pain. You've had knee surgery in the past. What concerns you most about this visit? Or what concerns you most about your knee? And I could say, I'm going on a ski trip. I need to know if I can ski. Do I need a brace? 10 minutes, boom, 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 we're done. Then he could say, hey, is there anything else? You interested in surgery? Do we need to do? I said, nope, I'm good. You've answered my question. I can move on. Now I would have saved him 15 minutes, right? So it's that kind of a mindset that we go in and we ask the patient immediately, what's the concern for this visit, especially if it's a repeat visit for things that have been a problem in the past. Does that make sense?
Yeah, it does, and I think you're citing the benefit there of being more efficient and more time saving for the busy physician. But I also think that there's a higher ethical value there, is that you're addressing the concerns of the patient. I mean, that's kind of why we're in the game in the first place here, right? Is to try and alleviate some symptoms or some worry in the patient. And so, yeah, we can always find something wrong if we start looking at other stuff. But I do appreciate you adding efficiency into our lives. But I mean, this is kind of why we're here, is to take care of people. So let's try and take care of them. So
yeah, and it's what's important to them, not what we assume is there because this is what the chart says is their symptoms or what it is they initially present with, right? And we always know that sometimes what they initially present with is not what they really came in for, because they didn't want to tell the person at the front desk, especially in the ER, right? We don't want to tell the person at the front desk we're really here for this, concern that we have, and we want to wait till we get in and see the provider before we do that. And if we address that right away, save a ton of time. I've just seen that happen so much, especially in the emergency department. We just
yeah,
come
Mark,
in and address the concern. Yep.
that's right. I prescribe Cialis, so I'm definitely familiar with that concept.
Exactly. So that's concern, and it sounds so
Yeah.
simple, right? So again, we do 2 or 3 hour workshops on this. If I'm working with your whole medical practice, we are walking through scenarios like this. We're talking about how do we do that? How do we have that kind of conversation? And that'll lead us to a little bit more of our coordination as we jump into the next topic. Unless you have other questions about this particular one.
No, Mark, I think you're doing great so far. Keep it up.
Good. So we move into this next one I call coordination of care, right? And if there's anything that frustrates, I have seen anyway, my experience, frustrates patients the most is the inability to communicate between either medical practices or communicate between even the people working in that particular medical practice. I come in and I present to the front desk and I say, here's what I'm here for. And they ask me a certain number of questions. And then, the medical technician or nurse, whoever, brings me back to the initial exam room or the exam room and asks me very similar questions. And then, 10 minutes later, the provider comes in, the provider asks me the same questions. And it's so frustrating. I get it. You want to know differently, maybe, and even you as a provider, you might want to ask a question differently than the nurse or med tech or front desk might do. I think there's this coordination of information that we could really sort of lessen this frustration with patients if we could some way communicate the information throughout. Let me give you a good example. So this is how I would coach it in a clinic. It doesn't work perfectly all the time, because what's the chances that everything's going to line up perfectly to this? But I always look at the what if this happened? What if I came in the front desk and I'm checking in for my appointment, and one of the things that the technician says to me or the front desk person says to me after they have introduced themselves and welcome me, they say, what concerns you most about this visit? And they write that on the chart, or they write that or type that in the computer. Then when the nurse or med tech comes and gets me from the waiting room, brings me back as they're introducing themselves, as they're walking me to the exam room, they say, hey, I'm reading here that you're really concerned about going on this ski trip and your knee's been giving you some problem. We'll make sure that we address that right away. All of a sudden, they don't have to ask me a question. They already know. That's the coordination of communication. Then doctor walks in, provider walks in and says, hey, Mr. Noon, good to see you. I'm provider so-and-so. Welcome, blah, blah, blah. Hey, I'm reading right here on the chart. You're really concerned about this. Tell me about that, right? It automatically makes them feel like you've paid attention. And then in my brain, I'm going, well, if they had that great of communication going on out there in the hallway, how likely is the care going to be great? How likely is if I had to have a referral to somewhere else that things are going to be communicated the way they need to? Does that make sense?
Absolutely. And you have suggested an implementation of something very similar in my practice, and
Mhm.
I've noticed some good utility of this in terms of, again, you're addressing some of the things that the patients are really concerned about, and it
Yeah.
does show well for your practice. It
Mhm.
does make you look like you are a well-oiled machine, even if you may not be a well-oiled machine. There's a
Yeah.
perception there that might actually be helpful. But I also want to that seems to be front end intra office communication. There's also a coordination capability of kind of all of the patient's care.
Yeah.
Maybe you have some thoughts about that as well.
Yeah, that's exactly where I go to. If they've had that kind of experience in let's say their family practice clinic, medical practice, then they're going to refer to, Gulf Coast Heart and Vascular. They're going to refer to see Dr. Davis for whatever the follow-up is. The assumption in the mind of the patient, if they've had that good experience, is that that information is going to be communicated when they go to their referral at your particular place. You might even walk in to the appointment and say, hey, I was reading your chart and you're really concerned about this, and from your referral, tell me about that, right? So you've already kind of got that information. They don't have to go through this long history. I mean, I get it. You want their history. You want to hear from them. But the fact is you already know some of it, and you're letting them know that you're paying attention to it. I think that's the element. It's like recently, I've gone through my with the Veterans Association. I've gone through my disability, trying to increase my disability, some different things that I've had happen over the last several years. And when I sat with some providers, typically virtually like this, once in a while in person, they literally said, well, I read this in your chart and I saw this in your chart. And that tells me they're paying attention. I don't have to reiterate. In fact, they're finding things, and I don't remember what date that happened. They're going, oh, well, that happened in July of 2006, and I'm like, if you say so, because the chart says it. They already have that communication. That's where I think multi-specialty practices, where you're getting referred to different places, or when you go from one place to another place in the hospital, you see a provider and they say, well, we need you to go to the hospital and go to the lab, and then we need to go to radiology, and we need to go all these places. They get there and they have that information already ahead of time. That's what causes the patient to go, wow, there's good communication here. I feel confident that I'm getting good healthcare.
Yeah, Mark, I usually broach the subject by saying, I've been talking about you behind your back.
It's a
And then
great way to look. Yeah.
yeah, and so we can kind of start off that way. It's usually, and I think best as a physician to physician communication. I don't know of too much that really replaces that on the front end or the back end, honestly.
Mm-hmm.
That kind of obviates a lot of communication barriers that can come up certainly when front offices start to talk to other front offices. So I'm a big advocate for that. Have you noticed any other things like that can kind of grease the wheels for overall patient care?
Well, I think it does, but it also brings a sort of a stronger bond between medical practices, right? It's like if you have certain medical practice, certain family practices, let's say general practitioners who are referring to you and you're getting good information from them, that bond between the two of you as providers is stronger. That communication becomes better. You trust each other more, and when you trust each other, that's going to exude to the patients. The patients are going to see that trust. And that actually leads us to our next part about confidence, which we'll get to in just a little bit. But it's that trust that's being built between providers as well as between patients and providers.
Mark, again, great point. You're really on a roll today. I'm really impressed. Usually you're not this sharp. This is why I'm really surprised. No, once that confidence comes in, this is the thing that I say more than anything is that you have to trust whoever's taking care of you. I hope that's me. But even if it's not, that trust, you're in a part of the Mississippi that you are not familiar with. This is a totally different world. And so you have to trust. I have to trust that the pilot's going to know what they're doing in case that something doesn't come up. I have to trust that the architect that's designing a building is going to be able to do those things. You have to trust me too. And if you don't, then that's a bad place for us to be. And we should find a different relationship where you are going to trust, because ultimately you can't know all of these things. Some would say I don't even know much about cardiology, and I might agree with them. But even in other medical fields, it's very, very difficult for me to be able to ascertain all the different things that I think you probably at minimum should know. So certainly patients are at an extreme disadvantage unless they trust.
Absolutely, absolutely. And the stronger the trust, the stronger the loyalty, the more likely they're going to return to see you, but also more likely they're going to do the things you've asked them to do. You said that in the very beginning is, okay, it's one thing to prescribe something to them. Now, how do I get them to do what I've prescribed? And that's the part where trust comes in. Then the confidence comes in. So we talk about this word confidence. How do we gain the confidence of our patients so that when we do say something, they actually go and they do it. They trust that we're going to do it. And part of that comes from connection, making a good, strong connection with them, something that we can relate to, something that makes them feel comfortable with us. It might be you're a very humorous person. That humor sometimes brings that comfort to people and enables them to just sort of feel relaxed and to trust you. Sometimes it's the confidence in their skills and their abilities. I was just reading a report earlier today where I think the one report I read said 35% of patients who are reading the Google reviews and other sort of things are looking for bedside manner. They're looking for the personality. They're looking for that comfort, that trust in the provider. 35% of them. It's not even about your skill. They assume your skill is there because you graduated medical school and you've been in residency or whatever. And that can be assumed, and that's a wonderful thing. But I think we use that to our advantage as well. You mentioned trusting the pilot on an airplane. There was a time I fly mostly Delta. I've been flying a lot for the last 12 or 13 years. And there used to be a time when Delta pilots would get on and introduce themselves. And they don't do this as much anymore, but they did. They would talk about their combined experience as pilots, from the cockpit. Now, you might have a guy or a woman who's been doing it for 31 years, and the person next to him has been doing it for a year, and you say we have a combined 32 years of experience. That sounds wonderful. You don't know that the one person only has been flying for a year, and you hope that person doesn't have to take over at any point. But it's the same thing. Michelle and I were talking about this before we started recording. As I get older, providers are looking younger and younger. So when I have somebody who looks younger or actually is younger than some of my children, I kind of go, well, hold on. How do I know they're good at what they do? Where's the confidence come from? And the confidence comes really from their ability to show their confidence, that they don't come in, shy or timid, which sometimes is hard for some of the different behavioral personalities. The other is, do we tell them that we're good at what we do? Or do we get built up to this, are we good at what we do? For instance, and I'll use your office as an example, just because I know some of the people there. If Gabby's working the front desk and a patient comes in and maybe it's their first time to see you as a provider, and Gabby welcomes them and asks about their concerns, and all of a sudden she says, oh, you're going to see Dr. Davis today. Dr. Davis is going to take such great care of you. He's been doing this for this long and loves medicine, doing everything he can to make healthcare better, whatever that is. That patient goes, wow, I hit the jackpot today. I've got the provider of all providers, right? And then the technician or nurse who brings them back and does their vitals and all those other things says something very similar. They're like excited for you to come in and visit them, right? And then here's where the other part of this happens. You've got to come in and deliver that, right? So they're sort of setting you up a little bit. And I know you well enough to know that you're going to deliver on that. But we've got to have that kind of trust between, and that's coordination of communication, that's concern, all of that coming together so that the patient feels that confidence in who they get.
Absolutely. And then, Mark, you can see where this can pay down the road, because if the patient has confidence in you and you say, look, you have a dermatologic problem, I'm going to send you to Jeremy Sunseri. This is a guy I trust with my own family. You're going to love him. You've already started that next domino to fall in terms of the patient's confidence, probably in the whole healthcare system.
Yeah, absolutely. That's exactly what I would coach somebody to do when they're going to be referred to somewhere else or whatever, is to say exactly that kind of thing. In fact, think about the restaurants that you'll go to. If you have a trusted friend recommend that restaurant, you will go at least try it. If they're not a trusted person or you don't know them well enough, I have this happen all the time when I'm traveling. People will say, hey, I'm coming to Destin, on such and such vacation. Where should I eat? And I'll list my top 3 places. And guess what? I've built this connection, this relationship with them in whatever capacity on the road. And they trust me. So when they come here, they're going to go to that restaurant, or they're going to, visit this attraction or do this particular beach or whatever, because of that trust, right? That's the confidence they have in you as a provider, in me and a recommendation. Make sense?
Yeah, absolutely. And I mean, you can kind of see how all of these things, starting off with the concern and the coordination and then leading into confidence, it's kind of a snowball effect that continues, and it hopefully self progresses every single patient, all the interactions that you have, and then this leads into your colleagues that are hopefully in their practice, and this leads to the whole community, and it just continues to snowball in terms of hopefully making the patient experience that much better.
And this is really a whole practice element, right? Because if you only do that solely and the rest of your team doesn't, it's not going to be a complete experience. They will say, yes, Dr. Davis was wonderful, blah, 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 but the whole experience for them may not be as good. Let me give you an example. Just recently, I had an eye appointment locally here where I live. I won't point out the medical practice. It was a good experience, but it wasn't a great experience. It started out great. I got the person who checked me in was wonderful, friendly, kind. They brought me back almost immediately. I usually try to get the first appointment of the day so I can get in pretty quickly. She brought me back. She introduced herself at least twice, possibly 3 times. She told me her name. She told me the other technician who was going to come in and take care of me, told me about the doctor. I thought this is what I would use as an example if I were telling people this is how it's done. Unfortunately, the second person came in and went right to business, never introduced herself, never really provided a greeting. Did she do a poor job? Not at all. But from a patient experience, I was set up to believe this was going to be, wow, I can't wait to see the next couple of people. They didn't deliver. The doctor came in, he was fine, he was good, but he was all about business, in and out, and we're done. And it's an eye appointment. I didn't expect it was going to be, like I was going to a luxury spa somewhere. But when you have that great experience with one and you don't have it with the other, I would probably rate them maybe an 8 on a scale of 1 to 10. The first person, I would have gave her a 10. I would have said, you are exactly what I would coach every healthcare place to be. But yet the overall experience now ends up being an 8. And on the scale of 1 to 10, 9 and 10 is the only thing that count in any meaningful surveys.
Yeah, and well, I mean, even though that's the only thing that counts in meaningful surveys, that should be the thing that counts to us too. I mean, that should be the way that, again, if we want to focus down on the patient customer service experience there, that's the kind of where the rubber meets the road. That's what we would like to be. So
sure. And that's what this whole time is about. How do we get there? How do we come together as a practice and say, this is the standard that we're going to set? This is what we expect. Or in the words of Gallup, when it comes to culture, this is how we do things around here. Anything less than that would be exactly that, less than that. And we don't strive for 8s. 8s are great, but they're not a 9 and a 10, and they really don't count for the patient.
Now, Mark, while we've got you here, can I say, besides getting you to make a bespoke coaching plan for your practice, noting its weaknesses, noting its strengths, what would you suggest as some generic advice to anybody who has a practice that is trying to grow it in terms of leadership, in terms of addressing these issues? What is something that we could do today, this week, this month?
It's really having a conversation with your team and saying, and here's what I find this happen a lot too, is what are the biggest concerns that all of your patients have? And let's say, for instance, I've done this with surgery clinics over the years. And it's interesting to me that this becomes the number one concern. I will ask them, what's the number one concern of all of your patients coming in, never had surgery before? And they say, am I going to wake up from the anesthesia? Okay, that sounds really extreme to me, but that is the number one concern of what they hear from their patients. So I would gather the team together. The first thing I would do is say, is that our number one thing? Okay, how do we fix that? Let's address it right away. Before we go through our checklist of all the pre-surgery stuff, let's talk about what concerns do you have? And they'll address that. Or you'll say, hey, one of the biggest concerns people have sometimes is anesthesia. They've never been under anesthesia before. Here's how it works. It alleviates all that anxiety, it gets rid of all that fear, and then you can proceed with the detailed information of what you need to do. But gather the team together, have that conversation, determine what that one thing is, and then move on and address that. Get better at that, move on to the next one, the next one, the next one.
Yeah. And what I'm hearing from this is really communication with your team. There's nothing like that. It's an ongoing conversation. I know that we have been trying to assimilate into our practice weekly practice meetings of various different groups together, but certainly at least once a week talking about that. And that feels like the bare minimum. And I know it's, some people would say, how can you afford that time to do it? You can't not afford that time.
Well, think about what I said about concern. If we can take what ended up being a 25-minute orthopedic appointment for me, should have been 15. We actually could have done it in 10, which saves 5 minutes. Imagine that times 20 patients a day. Wow, you just gained a whole other, a couple of appointments that you could put into the schedule, right?
Absolutely.
Yeah. Good.
Well, now, Mark, is there any other things that you wanted to address right now? I totally feel you in that. I think this is just scratching the surface on these topics, but I also think this is even a much smaller scratch on the surface of all the wisdom that I feel like you distill every single time that we talk. Okay.
I just put my information up on the screen. People can screenshot that to go to the website. Call me, text me, email me, whatever works for them. Like I said, we do a lot of workshops and we do a lot of one-on-one coaching and group coaching even. So it's what is best for your practice. What's the need? Like I said, I did this workshop up in Washington for this hospital. It was all about communication. It was all about some of the foundational elements of leadership. I do them very specifically to patient experience. Whatever the need is in that respect for you as an organization, I think that's what we need to tackle. And it's, the three things that we just talked about today, some clinics might already have that down and they're doing well in that. Okay, what is the gap? Where's the gap in your organization? Where's the gap in leadership? Where's the gap between the leaders and the staff? That's the things we need to address and bring some knowledge and some resources to.
Perfect. And Mark and Donnie, I want to thank you both. And I want to bring this full circle to the larger picture, which is Emerald Coast Medical Association. And the fact that you can take this entire conversation and now extrapolate it into every member being connected and the value of that to a patient. If every practice runs like a well-oiled machine and all of the members know each other, and when there is a problem with a patient, they know exactly where to send them and can pick up the phone and call them, that changes healthcare all along the Emerald Coast. And that is the whole point for me for this conversation today and providing really excellent and elevated healthcare by our physician members.
Yeah, absolutely.
Yeah, totally agree. And well, Michelle, thank you as always for coordinating this. Mark, thank you for what I assume is you're wearing pants. I don't know that for a fact, but
I knew you were going to say something about
that. I knew it was coming.
This was well, I'm not. That's why I was saying. I'm glad at least somebody's being responsible here. So I, as always, look forward to seeing you in person and hoping to get more of your insight every single time we talk. I'm looking forward to you meeting the rest of the board here because I think there's a lot of different ways that you can help us to kind of enhance our mission and then make sure that comes to fruition over time. And as always, Michelle, thank you for all the things that you do because we wouldn't be here without you.
My pleasure. Absolutely. Thank you both.
Thanks, guys.